Okay, let's move over to the third category that I wanted to talk about, which is targeting leukocyte migration. So we're going back to Jason Sister's lecture, and we heard about integrins and adhesion molecules and chemokines, and we'll talk about some of these and what we've learned from clinical experience. So on this slide, you see you remember the process of tethering and rolling and then integrin activation with more firm interactions, finally leading to firm adhesion and diapedesis between endothelial cells. And this is how inflammatory cells get from blood vessels to sites of inflammation. You heard about the role of certain ligands such as L-selectin involved in the rolling process. And what we'll talk a little bit about is some of these more firm adhesion characteristics, in particular the integrins alpha-4 and alpha-4 beta-7. Alpha-4 is the target for a monoclonal antibody known as natalizumab, which is an FDA-approved therapy in multiple sclerosis and an FDA-approved therapy in Crohn's disease. Alpha-4, natalizumab binding to alpha-4 is going to first stop interactions with the endothelial ligand VCAM1, which is expressed fairly ubiquitously at sites of inflammation. Natalizumab will also block the integrin heterodimer alpha-4 beta-7, which I will illustrate is a gut-specific signal by virtue of the fact that it interacts with the endothelial molecule that's only expressed in the high endothelial venules in the intestine of MADCAM1, and this is going back to Dr. Blumberg's talk. This was shown to be a highly effective therapy in multiple sclerosis. I showed you the rituximab data. This is essentially equivalent looking at natalizumab versus placebo at the number of new gadolinium-enhancing lesions in the brain, where natalizumab essentially arrested the disease process compared to placebo. Well, and maybe this goes back to Steve Holland's talk. We learned something very interesting from our clinical experience with natalizumab in people that we could never have anticipated or even had modeled in mice. And this was the occurrence at a fairly frequent basis, which I'll define for you, of a reactivation of a viral infection that then sets up shop in the brain. This is the reactivation of the JC polyoma virus, which causes the clinical disease progressive multifocal leukoencephalopathy. Prior to our experience with biologics like this, PML was really only seen in profoundly immunocompromised people, most significantly in the HIV epidemic. And in fact, even in HIV, since the institution of effective heart treatment to stop viral replication, the incidence of PML has gone way, way down in HIV. So this was initially described to occur after 1 year of therapy, so it was a late event in 1 in 1,000 patients. And I think the numbers are even more sobering than that when I introduce a few other factors to you. There's something about the adhesion process and trafficking of cells to the brain that seems to be important for this complication to occur, although there's certain fundamental questions such as where the virus lies dormant, why it becomes reactivated in the first place, and how it gets to the brain still remain to be answered. But suffice to say that one of the things natalizumab is doing is keeping inflammatory T cells out of the brain, and that's probably why it works in MS, but it's also keeping T cells that surveil the brain against infections like PML. That's probably why this complication has occurred.